Good morning, everyone. Thank you for taking the time to join us today for MVC's Chronic Disease Management Workgroup. Chelsea Andrews and I are the site engagement coordinators for MVC, and we look forward to facilitating this workgroup today. Next slide, please, Chelsea. Today's Chronic Disease Management Workgroup will feature a presentation by Holly Gould, Director of Quality Improvement and Organizational Excellence at McLaren Port Huron, a 186-bed full-service acute care general hospital located in Port Huron, Michigan. Holly holds an MSN with CNM certification from Wayne State University. She has a variety of experience across the continuum of care. For the first 6 years of Holly's nursing career, she worked closely with neurosurgical and orthopedic patients. During this time, she was also an adjunct clinical instructor at a local community college for first-year nursing students. From there, she began working towards her master's, where she then came to McLaren Port Huron and worked in the Special Care Nursery. Upon graduating with her MSN, she began a new journey in quality, where her primary focus was readmission reduction. Holly enjoys research and strives to share best practices with others to improve the quality of care at McLaren Port Huron. Thank you for joining us today, Holly. Before you begin your presentation, I'm just going to review a few housekeeping items. Next slide, please, Chelsea. First, this session is being recorded. The slides and the recording will be shared with the attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some designated time at the end of Holly's presentation if you'd like to unmute yourself and ask questions then. Lastly, your feedback is very important to us, so if you could please complete the post-work group survey in a link that will be provided following the work group, that would be greatly appreciated. With that, you are welcome to start your presentation, Holly. Thanks for being here with us.
All right, thanks for having me, and thank you for the introduction. All right, you can move to the next slide. So as it was briefly already discussed, this is a little bit about McLaren Port Huron. We're a 186-bed small community hospital, primarily serving St. Clair and Sanilac counties. We do have a variety of services. We are a level 3 trauma center. We are a stroke designated hospital, a variety of cardiovascular services. We have a bariatric program, orthopedics, and we also have a labor and delivery unit as well, with a long-standing history in our community of over 135 years. Next slide. So in the world of chronic disease management, I am going to talk about our navigator programs that we have here. We have a congestive heart failure and a COPD navigator. And so really, we kind of got to the space of having navigators to ultimately help reduce our 30-day readmission rate, which I'm sure for many of you is also a huge to-do on your list. So we started with CHF and COPD because those really have been continually, year over year, the highest readmitting population for us, and really a high population here in general. And so a couple of things that you see on the slide here, and these are actually pulled from Michigan Value Collaborative reports. Some of these come from the push reports that come out, and then some of this too came from a kind of deeper dive that we took with the collaborative to look into these two disease states. So looking at these and some of our data is kind of how we got where we are with these navigator programs. So that bottom piece there is the timing to readmission. So you can see the time frame, and then you can see, and this is for COPD specifically, that most of our population, not by a long shot, but comes back within that first week. And there's an article that I read quite a few years ago now, but it always sticks with me, that readmissions that come back within the first 2 weeks of that post 30-day discharge really can be potentially related to your transition efforts in the hospital and what happens while the patient's admitted. And then those last 2 weeks of the month really can be related to outpatient type services. So knowing that a majority of our patients are coming back within that first week and within the, especially within the first 2 weeks, tells us that we do have some transition work, on our end, on the acute care side to work on. And then those other two pieces on the right, that top figure there is the amount of comorbidities our patients have. So we know that, in these two populations, they oftentimes have another comorbidity, whether it's, CHF and COPD, diabetes often fits in there with, this population as well. And then that bottom is taken from one of our COPD reports, so that you can see that our COPD population, the largest comorbidity with that group is they also have CHF. So by having these two separate navigators, they've also kind of combined their work a bit, and they feed off of each other, knowing that if we have a heart failure patient that's here who also has COPD, there's a good chance that next time they come back, it's for an exacerbation of one or the other. And if they can tag team together while the patient's here and do some education and help them, we can, maybe mitigate any ED and unnecessary admissions that patient might have after that index stay. And so then navigating the healthcare system is really difficult. When we reviewed our data for quite some time, there wasn't always necessarily one thing in particular that we felt would really hit our readmission rate. It's just that, patients have, multiple comorbidities, they have multiple social issues outside, multiple medications, figuring out how to make appointments, what to do in an exacerbation, who are their resources. So there's just so many things that play into each individual patient and that can vary, that we really thought we would get the biggest bang for our buck by having these navigators to really help each patient with their individual needs. You can go to the next slide. A little bit about how our navigators work. So really first was identifying who's appropriate for these individual programs. Because really thinking too that it's our heart failure coordinator or navigator works out of quality. She was previously our clinical outcomes coordinator who was focusing on all of our readmissions. So we kind of just transitioned her focus and gave her a particular label so people would know how to reach her. And then our COPD navigator is a respiratory therapist. So she still does some frontline work and then also has hours added in as our navigator. So she has a lot of, respiratory experience and really has worked with that COPD population quite a bit. So knowing that it's one person that really is designated to these roles, we had to make their population manageable, because there's upwards of 50 patients at least that fall into these diagnoses that are, admitted into the hospital every month. But that's really not manageable workflow, for each person to really, work with these patients and do the follow-up that we're looking for. So just looking from a broad perspective, who would fit into the navigator programs, potentially someone that's going home, self-care, that might have some more limited resources than someone that might be going to a skilled nursing facility who has someone, with them 24/7, or potentially home with home care, to help coordinate with home care. If they have a new diagnosis, that's, can be very overwhelming for these patients. So really working with this population to get them to understand the severity, to get them to understand that they have this diagnosis. A lot of times we find that, verbiage can vary across provider, or the different care team that come into their room. So really, making aware of what their diagnosis is, what it means for their lifestyle, and then helping them navigate that after discharge, and making it a part of, their new life once they go home. Or if they've had a recent admission, so they might already be a readmission, or had multiple ED visits. That's kind of something new that I'll talk about later, that we're really trying to work with patients when they're ED, even prior to being admitted, to work with our ED case manager to potentially get them, a home care referral, palliative care, get them the resources they need in the ED, and sent home rather than being admitted. So the way they find their patients, they can be consulted. We have it built into our EMR to consult the CHF or the COPD navigator. A nurse can do that. Providers can do that. The second piece, which is where they get most of their patients, which does take them, most amount of time, is reviewing the daily census. So they each have some reports that they can pull from our electronic medical record and take a look at reason for admission, kind of that initial diagnosis while the patient's here, whether it's just shortness of breath or if they do have a heart failure diagnosis from the ED, and kind of taking a look at the chart and seeing if the patient would be a good candidate for the program. And then, like I mentioned before, navigator to navigator communication. So if our heart failure coordinator is seeing someone, they see they also have a history of COPD. If the patient's agreeable, they'll contact our COPD navigator and say, I've been seeing Mr. Jones. Looks like, he is here for heart failure, but he does have a history of COPD. I think he might benefit from some of your education, and a discussion from you. So that has been proven to be quite a benefit too. Next slide. So talking a little bit more about the workflow. So once the navigators identify that a patient would potentially fit into the program, they go up and introduce themselves, and they talk with the patient kind of about what the program entails, and really just, being open to them about how difficult, understanding the diagnosis can be, fitting it into their life, medications and all that kind of stuff, to get the patient to agree to be into the navigator program. And then they sit and they do an interview and try and understand maybe what they feel like the biggest gaps might be with this patient. Doing some brief education with them. Does the patient not know that they need to weigh themselves every day? Or do they, have a new medication that they aren't too familiar with? Do they express concerns with transportation or different things like that? And I do want to note too, a lot of these things sound like they come from the case management realm, and a lot of this discussion happens with them, and it does, and it's really a lot of coordination, because case management does a great job working with patients in the hospital. They coordinate with these navigators a lot to also give them some insight on, the follow-up piece that the navigators do with the patient, with follow-up calls, and certainly the navigators, collaborate with the case managers to make sure they're getting the proper referrals or equipment that they might need. So they really do piggyback off each other quite a bit. And so some key topics that they cover, within the program with the patients, a lot of them I've touched on already, but doing some disease-specific education. I'll show you some tools coming up that we have created for patients, because that was big with this program too, is revamping some of our education. Oftentimes we have these, pre-made workbooks that can be 50 pages long, don't have a lot of pictures, not a lot of interaction within the workbooks. And so those aren't very useful to patients because they end up just getting thrown into the stacks of paperwork they, get from here, and then they don't often use them when they go home. But there really is some valuable information. So we've really tailored our education, to the appropriate level that our community can understand, and something that they can integrate into their lives when they're going home to really make a difference. I touched a little bit on social determinants of health, medications. We do have what we call Discharge RX program. So that's where we can get the patients their first prescription, their first 30 days or whatever it may be, at their bedside before they go home. That way we don't have to worry about them, maybe not picking up their medications or having any difficulties there. So the navigators really do, push and stress the importance with that. We do run into some barriers because patients do get set in their ways, like many of us. They've been going to the Meyer pharmacy for 50 years, and so they just can't imagine switching pharmacies. But we've built it to where it's just a one-time fill, and the prescription still goes to their long-standing pharmacy that they've always gone to. We really work on follow-up appointments with the patients. We stress the importance of going to them, especially with our high-risk population such as this. Timely follow-up appointments are very important, so making sure they're getting into that, 3 to 5 days, maybe sooner, depending on the patient, to really help, maybe clarify any medication concerns, anything that might have been missed from a medication standpoint, any questions, or, any of those short-term issues that bring patients back very quickly. Like I had shown, our patient population here most often comes back a little bit quicker. Follow-up phone calls, so we let the patients know that they'll be getting a call from the navigator that they're talking to right there. So it's nice that they do have that interaction, with the same person that's going to call them. It increases the likelihood that they'll answer the phone. And it really depends for each patient how soon and how often the navigators call them. Usually they really try and touch base within the first 48 hours. But they also recognize too that can be an overwhelming time frame. They're getting home, getting settled in. If they have a home care referral, there's a chance they might get a call by home care within that time frame and have been seen by them. So, they do recognize that. And if the patient, stresses that they'd like to be called, a couple days farther out, then, we certainly accommodate that. But then also letting them know that we're going to stay in touch for the 30-day time frame. And so they might get a call, 3 weeks from discharge to check back up on them, see how they're feeling, see if there's anything that we can help them out with, any education reinforcement that we can do. If the patient is a readmission, we have created a readmission interview template to really get the patient's perspective why they feel that they came back so quickly. Is it that they felt they were discharged too soon on the last admission? Was it something that felt like they needed that we didn't provide them or they had difficulty getting? So really getting the patient's perspective, because we can, dive into some data and, put all these trends together, but really getting the perspective of the patient can really put a good story together on some improvement opportunities. And then also equipment management. And this is something that we've noticed within our COPD navigator program, is that patients with BiPAPs and CPAPs and, not understanding how often they should be cleaned, and patients saying, oh, I didn't know I had to clean that. I've never cleaned that before. So there's really a lot of concerning things that come up, when you really start working with patients this individualized and this closely. It really kind of helps things that you need to teach every patient that you kind of take for granted that everyone understands. So really, if they use any equipment, even like nebulizers and things like that, breathing treatments that our COPD patients have to do, really making sure they get that in-depth education on how to properly provide themselves the medication and maintenance and things like that. And like I said, the patients are monitored for a minimum of 30 days, again, depending on the severity, how often they come back. If it's someone we've been following for a long time and they know that, even after that 30 days, we're going to see them again, they might do another follow-up call or, kind of stay in touch with them a little bit more. Next slide. So, and I've probably already touched on some of these through the course of discussion already, but identified opportunities, while we've been kind of within our navigator program is gaps in education. Patients may not be aware of a diagnosis. So patients, especially that we might not have seen, maybe on their index day, and we're just getting wind of them when they're a readmission. Oh, the doctor said I had CHF, but you're telling me I have congestive heart failure. Again, something that we might take for granted, we recognize as the same thing to patients that could be two totally separate things. And that patients do want to learn. And again, with us having the understanding that we do, not always recognizing what patients don't know. That patients need tools they can integrate into their daily lives. And again, I'll show you those in a little bit. We've learned some of the struggles that patients have had, making timely appointments in the community, understanding what resources are available to them once they leave, because oftentimes they really think that, the ED is their resource. And so they do tend to come there prior to, maybe calling the office or even calling, one of our navigators prior to coming in. Discharge medication discrepancies and lack of communication between the care team. I think, probably everyone can relate to things like this. Some patients who have multiple consultants on a case, if all of the recommendations aren't captured appropriately at discharge, recommended follow-up gets missed, or maybe changes in medication dosages that was recommended by one consulting team, but not captured by the attending. So these navigators, because they do work on these patients, so in depth, they review their discharge medications, hopefully prior to discharge, sometimes not till after. If they catch any discrepancies from the consulting teams, they'll reach out to the primary care providers and say, I think Mr. Jones really needs to get in. It looks like it was recommended that his Lasix be increased to 60 milligrams, but he was only discharged on 40. So, working through those little tedious issues that we really do feel like have saved some readmissions. Next slide. You can go to the next slide. So these are some of the tools that we have integrated into our education. So this one right here is one that we're partnered with our local skilled nursing facility, Marwood. So I'm sure many of you have seen the different stoplights that different diagnoses have. I know some of the most common ones are for CHF and for COPD, but we kind of worked it into a daily kind of checklist for patients. The top part there is where they can put their weight and what the date is. And then we just took all the pieces that are on the stoplight and made it into like a little checkbox format for them. So the idea is, when they weigh themselves, they take a look and they kind of mark where their symptoms are at. So if the patient typically, is finding that their symptoms fall within that green spot, but maybe then over the next day, over the next couple days, they're noticing that their symptoms are falling into that yellow. They can be reaching out to someone, like they're one of their providers, calling one of the navigators to say, this is how I'm feeling. This is different from where, I normally am. What are you suggesting? Maybe the provider recommends an adjustment in medications. Maybe they want them to come in and be seen. But really the hope is that they're capturing these symptoms before they're getting to that red, where then the patient ultimately has to come back to the hospital. And some patients, them recognizing that baseline for them might be in the yellow. So if that's where they're consistently at, it wouldn't be a concern to them if that's where they stay. But then knowing that if they get into that red, that they need to take action. Next slide. This is what we call the heart failure passport. So this slide and then the next slide, it's a little trifold pamphlet. So the back has our stoplight. And then if you go to the next slide, the inside has some pieces for them to write a little bit about their diagnosis. So this is, again, for heart failure. So it has a spot where they can write their ejection fraction, some of their medications. They can write down follow-up appointments, what allergies they have. And so the idea is that this is filled out in the hospital, and then it can go anywhere with the patient. So if they go to a skilled nursing facility, if they're seen by home care, whenever they go to one of their different providers, this gives them a spot to, add things to it. And then it's just a quick touch point too for the providers, maybe to get a little bit of information about this patient. Next slide. And then this is one of our newest tools that we made, and this was something that was identified by the navigators, is that the patients are very engaged, or they appear to be when they're in the hospital. They interact very well with the navigators. They seem eager to learn. They want all the resources, but then it's almost like, then they're feeling well. They get discharged, they get home, and they're like, okay, things are great. I feel back to baseline. I'm good. And they almost forget that they need to maintain that, and that there's things that they have to do to maintain that, and that it's not just maybe 1 week post-discharge, but it's a longer time frame that they need to be monitoring their symptoms. So they put together this 30-day care plan that kind of goes out different days into different, or the weeks after a visit, to kind of give them some reminders on what they should be thinking about, what they should be doing, maybe who to contact. That kind of thing, to give the patients more of a perspective that this is a long-term goal and a long-term change that they do need to do to maintain their health and, keep themselves healthier. Next slide. And so the other thing that we've learned through this is that communication is key. And these navigator programs really have opened the door for us to really build on a lot of communication with different individuals in our community. So our local skilled nursing facility, Marwood in particular, that we work probably the closest with, we have specific individuals there that our navigators work with. If they have a patient that they see here and they know are getting discharged over there, they'll give them a call, give them a little report, a heads up, kind of some things that they've noticed about the patient. And then we do have a meeting every other week to kind of talk about some of our common patients. If any patients have returned, we dive into them, talk about, maybe some issues on either end, opportunities for improvement. And then we've also moved that out to the home care setting also. We have monthly meetings with our local home care agencies and really do the same thing. We go through some data, we go through individual patients that have returned, some patients that we've had enrolled in the Navigator programs that we know are going over there, giving them a little bit of heads up on some things, maybe family dynamics that we see, or just anything that we might know that might be able to help them to make the transition successful for the patient. We have an ED case manager that I've spoke a little bit about. That's a little bit of a newer role for us as well. And this role has been outstanding. So whenever a patient comes into the ED, if they have CHF or COPD, our ED case manager is consulting our navigators. So either the navigators, if they're going to be admitted, they just have a really early heads up to get everything rolling once the patient gets settled up on the floor. Or if it's something that the ED case manager, the navigator, and the ED provider think they can, work on the ED and get them discharged safely home, they work on it from that perspective. So some things include, palliative care referrals, having those advanced care planning discussions, and maybe hospice is appropriate for patients that have had frequent admissions or they've just reached that end of life point. The navigators doing some education right out of the ED, getting them a follow-up appointment timely, and getting them home. And then we also have multidisciplinary meetings with case management. We have one a week. The case managers pick a patient that that's either admitted or that they've maybe recently discharged, that have had several recent admissions. We get the whole care team together. We invite the PCP from the community, whoever's the attending here. Our CMO sits on this, the navigators, case management. If it's a patient that has home care services, if it's a patient that's been to a skilled nursing facility recently, we invite them. So to really all collaborate on what each discipline has been doing, what they notice the gaps are, to really come up with a plan, something that we haven't tried yet for this patient, to safely transition them and keep them out of the hospital. Next slide. So recently, in the Navigator programs, like I said, they're always evolving because they're really always helping us understand where our opportunities are. And so I think I briefly mentioned that I think one of the greatest successes of the Navigator programs are the work that they do with the patients once they discharge. And so we want to make sure that they have the most time possible in their day to, not fall behind on those follow-up calls, and, really be sure they're making those to help be a resource for the patients. So we've transitioned a lot of the patient education that the navigators were doing to the frontline staff. On the right there, you see, this is the congestive heart failure patient education checklist. So we've done it for CHF, COPD, and actually we did one for stroke. We have these individual patient folders that have some of the tools that I already showed you, the education booklet, the flyer for the navigators, for the stroke one for our stroke coordinator, and they're up on the unit. So when a patient has one of these diagnoses, the nursing staff is passing out the packet, and then this is their little checklist for them to know what they need to touch on with the patient while they are here. So we've done some education with the frontline staff about educating patients. I think with a lot of turnover, we have a lot of young nursing staff, especially that came out or that were in school during COVID, when, really the idea was you're in a patient room and you're out with the large COVID population. So I think education kind of fell to the wayside. And I think with, the different nurse ratios that we have now and the short staffing, education easily has gone to the wayside, and trying to bring back how to roll it into your day-to-day workflow. You don't need to think of education as something that you're supposed to set aside, 2 hours during your shift, but when you're in there, maybe helping clean the patient up, when you're helping toilet them, when you're in there, scanning their medications, that's an easy 10 minutes that you're in there. So pick something on this checklist to educate about. And the idea is that the patient should learn nothing new on the day of discharge. So on the day of discharge, this checklist should be completed. The navigator would have come up to introduce themselves to the patient, and then the patient should be ready to go, not feeling overwhelmed on that day of discharge. And so this will kind of alleviate all that time that the navigators were doing a lot of this education and identifying the population, and they can be really working with the patients more after discharge and, doing more follow-up calls when appropriate, working with the offices to coordinate care with these patients, really all those things that we know kind of have contributed to admissions after discharge. Next slide. So a couple tips and next steps. So just a few suggestions I had was really to look at your data. Those first couple data points that I showed you in one of the first couple slides that kind of led us to, choosing navigator programs as our, best practice for us here, was just looking at what our data told us. So utilize reports that already come to you, or if you have databases, different things in your EMR that you use, really take a look at your data. And I use this example a lot because it really kind of woke us up on what we needed to work on here. Is that, follow-up appointments are our best practice. Timely follow-up appointments, getting those high-risk patients in quickly has always been one of those, opportunities and something that's identified to help reduce readmissions. So that was just something right out of the gate, really before looking at data several years ago, that we thought we needed to improve. So we, dug into each unit. What is their practice for making follow-up appointments? And we were auditing and monitoring their follow-up rates, working with offices that wouldn't give follow-up appointments or save slots to get patients in. We were really putting in a lot of time and effort. And then it was one of the fall MVC semi-annual meetings that we went to that was on follow-up appointments. And it was a previous year's report that I think we were one of the top couple hospitals for follow-up appointments within 7 days of discharge. So that really hit us to think, our community does a great job on getting patients seen, and our patients are keeping those appointments and getting seen. Because on our end, we don't have that billing information. So we see, we made a follow-up appointment, but do we really know if the patient went? So the great part about the Michigan Valley Collaborative data is that we know that the patient's seen because it's, it's based off the billing and the coding information. So then it made us go back and reflect on what we're doing. Should we really be spending all this time on increasing our follow-up rates when we know that our offices and our patients, that they're doing their job? So then it helped us look at our data a little bit different and shift our focus. So I really do encourage everyone to really take a look at your data and build your story to see, where your opportunity lies, especially with how limited resources can be. Always be willing to make changes. We have these navigator programs now, but what they're really doing is identifying where our gaps are. We recognize that we need to communicate with all our community partners with, even different disciplines here to really do what's best for the patient, and then know available resources. So, recognizing that, different provider groups, they may have, for us, one of our provider groups, they have care coordinators. So how can we work with them with resources that they already have to make sure our patients know about those resources, that we refer them if we can, because I think everyone's doing the same things or has the same goals, but it's just kind of how to get on the same track and the same page to align everything. Next slide. And that's it. Anybody have any questions?
Thank you so much, Holly. We can open it up to some questions now. We have one question in the chat from Devin. Could you talk more about how you use the billing reports to identify if a patient is seen? In Marquee, we ask for a billing report on specific procedure codes. Is there a list of ED or readmission codes that would help sites track these?
Well, maybe the two of you might be able to answer that better, because correct me if I'm wrong, but the Michigan Valley Collaborative follow-up appointments, I mean, that's based off not if an appointment was scheduled, but the patient has to be seen for them to show up on those reports, correct?
Correct.
Yeah, so that's how we've been, I mean, because we can pull reports on our end that show, are we making the follow-up appointments? And then that's how we can compare it to, using the Michigan Valley Collaborative data, for example, to see if, our patients are really being seen. Because that is a concern for, I know, offices sometimes when we've tried to do some improvement initiatives with them saving slots or, really discussing the importance of getting patients in timely is that, no-show rates can be high sometimes if we don't work closely enough with patients, to make sure it's the appointment that they want within the time slot they want and things like that.
Yeah, and we do have, the MVC, for the sake of referring back to the initial graphs and charts that Holly included in her presentation. The MVC does have a list of procedural codes that we can offer to members for comparison when they're looking at their EMR data to compare what is classified or what is included in an MVC claims data point anyways. So if that's something of interest, we do have that available on our website and we could direct members to that.
We have another question in our chat from Marjorie. Do you have any comments about using predictive modeling for readmissions? For example, help maybe focus stronger efforts on those identified as higher risk for readmission?
So here we use the LACE tool. So if anyone isn't familiar with that, that is their estimated length of stay, other conditions or comorbidities they might have, and then if they've had any recent ED visits. So case management completes that on every patient. And so we have talked about, and we do have reports that we've ran. We do have the LACE tool up on the nursing, like their status board is what we call it. So all of their patients that they're assigned for the day, they can see the LACE score. So we've done a lot of education to try and kind of add some bulk to that LACE score that, if a patient is, I think it's either 10 or 11 that's considered high risk. If you're taking care of a patient or, for case management, if they assess a patient and they have a high LACE score, what are you doing different with your care of that patient, to recognize that they are high risk and that they might, return to the hospital? So can they, do some different disease-specific education? Are there some questions that they can be asking about, if they're making a follow-up appointment? Is transportation an issue? Just whatever it may be. We've tried to do a lot of education about using those tools that we have built within the EMR to help staff to recognize, maybe some different things that they need to be doing with the patient. How successful that is, I don't know, because I do feel like a lot of times when we've reviewed data and things like that, the patient was identified as high risk, but there wasn't a follow-up appointment made, or it didn't really look like they got a lot of disease-specific education. So we don't really always feel like that score is being looked at, and that, maybe some changes are made based on what that score is.
A follow-up question, is LACE a standard tool or is that something only in Epic? I have seen that in the past when in clinical settings, but I've only had experience in Epic.
We have Meditech, and that is the one that we built in there. I do know Cerner and uses Boost. And that one's a little bit more specific, and I feel like captures a little bit more in depth, capturing the social determinants of health. And that one I don't think, like if you look up the actual Boost tool, I don't know if it necessarily scores. It's just different questions that can maybe help or identifies different high risk areas and know what questions that you could be asking patients to maybe identify where some of their high risk areas might be. And those are the only two that I'm familiar with.
I have a question for you, Holly. Could you tell us about some of the biggest barriers that you've faced thus far in implementing these programs?
I think, with many quality improvement efforts is buy-in. I touched initially on how the navigators get their population, and a lot of it is by looking through, the daily census and identifying what patients might be appropriate. That requires, looking at the census, taking a dive through the chart and seeing, have they been seen by cardiology? Is this an actual diagnosis that they have? So I think the biggest struggle has been getting provider buy-in to put in consults. Because if they're putting in consults, then those are patients that the navigators automatically know would be a good candidate for the program. They can get up and hit the ground running. So I think that really has been one of the biggest barriers. Getting the ED case manager on board has really been a big help when she's consulting the navigators right out of the ED, because then they can see them early on. Sometimes when we get provider consults, they're consulting the navigators on the day of discharge. So the navigators miss the opportunity to work with the patient while they're here. And then, what's left for them is to call, do some education after discharge. And so they kind of miss the inpatient piece with them.
Great, thank you. And a follow-up to that, I know that you detail in your slide kind of at the start of the program, someone introduces, the program and the overview of it to the patient. Do you experience any like patient level barriers where there's no buy-in there, where patients don't want to be engaging with these programs?
Yeah, I think, one of the more obvious ones is sometimes patients, they are, they might be more acute when they're here, so it just might not be a good opportunity, might not be good timing. So they do revisit the patients, day after day to see, the patient is improving. Yes, it's getting closer to discharge, but the patient's more open, a little bit more stable, to kind of, have these discussions. And then, yeah, there are patients that just, whether it's a denial factor that, oh, I'm okay, I understand everything. Or, they have families, so they feel, my family's really engaged, so I don't need any additional help. So then we see sometimes where if they are a readmission, the navigators will try again, and then they'll be open to it. And I think that's one thing we see with our readmission population is, especially patients that have been stable or haven't had, many medical issues, when they come in and are faced with something like that, it takes them a few admissions sometime to realize or accept some of the resources that are offered to them. So we'll see that with our higher risk population. They'll come in and, no, I have family that can help me. I don't need to go to skilled nursing facility right now. And then a few days later they come back and they want to try home care first, and then they're back a week later and they decide, what, I do need to go to a skilled nursing facility. So we actually started recently holding some advanced care planning and educational seminars for our community to talk about different resources that are out there, and to talk about, when they should accept them, with the hope that, word kind of spreads a little bit and they accept resources that are offered to them, sooner rather than later. Because, patients don't want to come back, I wouldn't think want to come back. They want to, be home and back to their environment that they're most comfortable with. So.
Great. And then regarding like integrating family into the care plan, do the programs kind of provide that educational piece to family members as well, or is that more geared towards like individual level conversations with the patient?
No, the navigators definitely love when, family is available. That's one of the questions they always ask if they don't see family in there. Do you have a lot of support at home? Who is your support? Because they'll communicate quite a bit with family if they can. And if, if there's family that's available in there, they'll certainly have, the educational sessions and discuss things with them. And they'll even ask the patients if they don't have family at the bedside, do you want me to wait until family, is back in the room? I think oftentimes too, they pick up what's going on in the room. So if they feel that the patient themselves isn't necessarily very engaged, but they recognize that their significant other might be, then they'll do some follow-up calls, and really target that significant other to see how they're doing, see what help the patient might need, because oftentimes the patient might say, I'm good, everything's fine, I understand everything, I don't need any help.
Awesome, thank you.
I have a question about sharing the best practice and, extending its reach and sustaining it. It sounds like this is specific to McLaren Port Huron. Are there any other hospitals that you're aware of in the system that use the Navigator program? And if not, are there any conversations happening about extending its reach or use?
We actually got the Navigator program idea from our McLaren Lapeer partner. Several years ago. I'm pretty sure it was before COVID. It's kind of hard to tell what was before and after anymore, but prior to COVID, they did trial a COPD Navigator program, a little bit different than ours, because I believe their Navigator also went into the home setting, and they had a great deal of success in reducing their COPD readmission rate for that time frame that they trialed the program. I don't know if they're still doing it, because again, resources are limited, and I do believe they might have gotten some funding from like a foundation or a sponsor to kind of trial that program. So I really don't know how it's doing, but that is what gave us the idea to do that really individualized care with our patient population here.
Excellent. That's great to hear. That's at different sites and across different populations.
Does anyone have any other questions for Holly? Okay, Chelsea, do you mind bringing up the presentation again? We can conclude with some, I see one question from Margaret. Have you seen a decrease in readmission rates?
We have for these two populations, yes. Our overall readmission rate, no, which is frustrating. But I think, what we've learned from these two programs, we're now disseminating to other disease processes. Our AMI readmission rate is a little bit higher than we would like right now. So we're kind of taking what we've done with making like the individualized tools and the packets and the follow-up calls. So we're kind of, as we transition a lot of the education to the nursing staff for our CHF Navigator, that's going to give us some time to hopefully, focus on AMI to see what we can do there. So I think these Navigator programs are evolving. It might not always be CHF and COPD, but hopefully these designated individuals can kind of transition where we need them and, get those specific disease states on track, doing what's best for our patients.
Great, thank you. Thank you, Holly, for that really informative presentation. It's always great to learn about what our members are doing to improve the care within their hospital settings. So thank you again for joining us today, and thank you everyone for being here today. Before we conclude the work group, I just would like to review a few upcoming events that we have for MVC. We have a diabetes work group scheduled for July 19th, and that will feature Sure Health with presenters Brenda Gleason and Carly Kungdinger. And that is going to go over the coordination of care between care management and diabetes education and how those kind of interlay to improve the care of diabetes populations. We also have a preoperative testing work group on August 1st that will feature Nick Berlin, who is a fellow at the University of Michigan Department of Surgery. And then on August 9th, we will be having a rural health meeting. This will be a virtual meeting geared towards delivering high-value care in rural and northern Michigan. We will be having an unblinded data presentation by MVC, which will focus on our rural health members. And then we will also be having presentations by Ross Ramsey, who is the CEO and president of Sure Health, and then Mariah Hesse, who is the president of the Michigan Critical Access Hospital Quality Network. So we hope to see you all there. Next slide, please. So thank you again. As a reminder, the recording for this group, as well as the slides to the recording, will be shared in an email following the work group. If you have any questions, please reach out to us. Additionally, moving forward, if you or someone you know may be interested in presenting at an upcoming work group, we are always looking for topics and ideas, so please reach out to us. And then as well, as Holly mentioned during her presentation, MVC is more than happy to meet with our members to discuss any custom analytic options. So if there's a specific area of care condition that you'd like to look into further, we'd be happy to meet with you and discuss the feasibility of that. So as always, please reach out to us if you need anything, and thank you for joining and have a great day. Thanks again.